to welcome you all to the first departmental seminar for phase for 2026. Those in the room have some fringe benefits. Lovely to have you here. Thank you to Tamani and everyone for on the organizing side. It's really a pleasure to welcome Oliver van Hecke back to our department. Many of you know Oliver and the work he's been doing. Oliver van Hecke is a South African trained doctor, worked in the UK and is now based in Belgium at the University of Ghent. Where he's also the director of the WHO Collaborating Centre on Family Medicine and Primary Healthcare. Many of you know that, but the previous director was Professor Young, the Naismere. So, Oliver has a particular interest in primary care, antimicrobial stewardship, and has been part of an interesting project which you're going to tell us about today. Previously, I think his work was also quite always nice to see how interdisciplinary your work is, working also collaborating with UWC's pharmacology department and many other colleagues in the room. So you're not new to Cape Town and primary care, but it's very exciting to hear about this latest development, and we look forward to your talk. Thank you for being here. Yeah. Thank you. Thank you. Over to you, Oliver.
Good afternoon. Can anyone? Yeah, I can hear me. I think online. So thank you, Klaus, for those kind words. And always good to be back. I would say home because this is where I grew up. So briefly, I think today the seminar is so my interest, particularly in research, and particularly infection in primary care with a bigger scope in terms of antimicrobial stewardship, particularly in primary care. So that's where I come from. And we've done a little bit of work around sort of what happens, particularly in the Cape Metro region, in terms of prescribing, and particularly in primary care. But then there's a bigger topic as well around sort of rheumatic heart disease, because South Africa is one of the countries that we still have rheumatic heart disease, but there has been significant progress. And I think one of the, the topic is really around sort of balancing the risks of rheumatic heart disease and also antimicrobial resistance, particularly in the Cape Metro region, but it has implications for the rest of the country as well. These are my disclosures. I don't have any, apart from the fact that I'm a parent to ones who are here, both sick. But I'm hoping that South African sun will actually cure them with enough vitamin D. And I also love supplements. I do also want to acknowledge, the people here who contributed to a workshop that we did end of last year. And these are particularly people from Western Cape Government, UCT, the Knowledge Foundation here based at UCT, and then also the Children's Heart Disease Research Unit, the School of Public Health at UWC, and also here as well. I've just put out references for references that you. So basically, what I want to do is have a very short introduction and try to build up the challenge for South Africa. Mainly focus around sort of the stakeholder workshop that we did at the end of last year, and sort of some of the key findings, but also what the implications are of those findings, and trying to find out sort of opportunities where we can actually change things. And obviously welcome discussion, Q&A. I'll allow me time for that as well. So the challenge really is can we actually better identify children with sore throat infection? So just for those of you who are not familiar with it, so we focus on rheumatic heart disease, and obviously the main cause of that is Streptococcus bacterial infection of the throat. So that's the main concept around. I appreciate that there are other sort of skin conditions like vitiligo that can also cause it, but our focus here today is on sore throat based on what's happening here. And the issue is, can we actually identify better children with sore throat infections that would actually benefit from antibiotic treatment here? And the reason I bring this up is obviously sometimes we all work in our little silos. Me in particular, I guess also primary care. But sometimes, we start, as Klaus mentioned, we go sort of interdisciplinary in other areas. If you zoom out and say, actually, what is the bigger picture? What are we actually trying to do? There's clear implications for two really big important topics, but each one is actually working in their own silos. And so this is really kind of trying to actually solve that. So are the rights of children at risk being treated with antibiotics? Because rheumatic heart disease is an important condition, and we do need to treat those children with antibiotics. But you'll see from we know that the situation isn't perfect, but we need to also make it a better solution. So this is around some of the segment of the workshop, and then we advertise and work with the workshop just to get across the way in Grimsby, where we invited the key stakeholders, particularly the primary care clinical team, so that's the family physicians, medical officers, nurse prescribers, and pharmacists working in the greater Cape Bedford region, microbiologists, also infectious disease specialists and researchers based at the CT, public health doctors, and some policy makers within the Western Cape government. And the aim of the workshop was really trying to bring all these people together, trying to identify where and how we can actually improve the management of sore throat, particularly in children, because that's where most of rheumatic heart disease, all rheumatic heart comes. And in particular, our focus is on the public sector. Okay. And so what I want to do, before we actually go into the findings, really to just briefly describe to you what happened during the workshop, because that's quite important to know. And so we had four different things, so four different talks, I guess. We briefed what the scope of the workshop, but then we gave individual presentations on firstly the burden of rheumatic heart disease in South Africa, and that was from the Clinical Research Heart Institute here. Then we also had a local family physician give a talk what really happens in primary care around the context of rheumatic fever, rheumatic heart disease. But then we also focused on a study we did called the PRINCE study, very small observational study that gave an insight as to actually what happens at primary care facilities in the Cape Metro region. And then the last talk was comparing sort of what happens in a high income country, where we're obviously dealing with children where there's a low risk of rheumatic fever. What we did then was we divided into smaller groups and focusing on the challenge as such, and trying to come up with solutions that might actually be effective. And then we came back into a wider group of further discussions and key suggestions for future interventions or opportunities for debate as well. So what I plan to do in the next sort of 5 minutes or so is just to give an overview of the highlights of each talk. And I'm grateful for the slides. I acknowledge the slides. These are not my slides. These are my slides. I eliminate responsibility for them. And this is obviously just for people that are not familiar. We're talking about group A strep infections, so predominantly sore throat, and sometimes skin infections as well. In the context here, it's mainly sore throat in South Africa. And we're focusing here that these are sort of the common areas why it's happening still in South Africa, low middle income, or middle income country, but still here. And some of the things got to do with this, some of the things have got to do with that. But you can't really, you don't know which children actually get it. Because some children, but when you do get sort of acute rheumatic fever, difficult to diagnose. Okay, it's not that straightforward, even though we have some criteria. And so what happens invariably is that people go to the default where you just prescribe. Okay, but obviously has devastating concepts of where you have rheumatic heart disease, chronic valve damage in the heart, and lots of other things as well. So very complicated side, but that's not the purpose. But this is the sole purpose. So thank you to Lila from the Children's Heart Research Unit. And this is a public presentation from 2015 by Professor Oliver van Hecke, who obviously is well known. And then since then, so where we can look at sort of the instance of rheumatic heart disease. This figure 20 is from 2015. Okay, and since then, so this is not published data, so I can't share it with you, but since then, South Africa has made substantial progress in bringing the incidence of rheumatic disease down at least half. Okay. Despite there being not actually a formal control program, so there have been substantial things, and particularly rates as well. Okay. But the main thing, I guess, would be so we know that we've made significant progress in this area. The second talk was around what do primary care clinicians here do? Okay, and the main thing was really to go over the criteria that are used to make the diagnosis of streptococcal paralysis called sore throat. Okay, we can see that it's obviously a sore throat whiskey, you have cervical glands, the absence of a runny nose and cough, and you have obviously pus and exudate on your tongue as well. The main thing is, and what you can see as well is that there are 4 different guidelines that are used in primary care. And the question that we asked at the time was, well, what do people use here? Because there are sort of subtleties in each guideline. Subtleties, if you actually compare them, there are slight differences. And we'll come to that point, an important point later. The third talk was around the PRINCE study, which looked at an implementation study looking at what actually happens in these primary care facilities. And although and we focused particularly visible at both adults and children, but we looked at sort of the sample that we had in children in particular, where we looked for what do people prescribe for sore throat. And although the focus of the study wasn't necessarily on sore throat, but you can see that in the yellow boxes, almost all children and adults were prescribed an antibiotic. All of them. Okay, 97% were prescribed for sore throat. Okay, and you can see the types of antibiotics. The types of antibiotics were almost all amoxicillin. Okay, for this time as well. And the last point was around what other options are there. And the first thing to acknowledge in this top right one is that children are much more likely to carry sort of commensal group A strep than adults. Okay, that's the first point you need to know. So if you have, and that complicates the picture. The second that we focused on was the takedown clinical decision rule created by Mark Engel and the team, and we focused on the probability of using sort of a clinical decision rule in terms of how are we likely to predict the probability of a child having group A strep, and it's based on sort of the criteria that I showed you earlier. So you can see the brief on the statement quite small to people in the bank, but you get sort of a scoring system or weighting. So each symptom has a scoring system, and you can see probably can't see here, but you can see if you have 2 or more points scores, the probability of having this group A strep, well, positive predictive value is only 20%, or just over 20%, okay, which is the same as by chance. Okay, just to bear that in mind. Okay, and then we focus as well in terms of point of care strep. So this is something that's commonly used in high-income countries, but remember the days of low risk. Okay, and we tried, I did, but colleagues at the heart leaders try to actually do the same, but in the setting, and you can see here that it actually performed quite poorly. Okay, so i.e. A positive predictive value only over 10%, meaning that if you have a positive predictive, so a positive point of care test, only 1 in 10 individuals will actually have a significant group A strep. Okay, so it's, very different type of thing. And hence, that's one of the reasons why a point of care test currently is not used. Partly because of cost, but also because it doesn't work very well. So, okay. And so people went then off into their small group discussions and asked, trying to discover these 2 central questions. So are the right children at risk being treated with antibiotics? And what sort of strategies can you actually implement in these public sector primary care facilities in order to optimize the treatment of children with sore throat? So this is the people, so we included 21 participants, ranging from the stakeholders from family medicine, from the Children's Heart Disease Research Units, knowledge translation scientists who deal with the guidelines, particularly one type of guideline, the PAC guidelines, public health policymakers from the Western Cape government, infectious diseases and pharmacists, and one PhD student. And there were two main areas. I've really simplified this, but two main areas. And one was around sort of the clinical assessment and diagnosis of acute sore throat. And the second was about sort of the recommended treatment of acute sore throat according to the guidelines as such. And in terms of the findings, I'll just take in those two findings. So the first thing to say is that participants voiced that there's a need to better identify children. They realize that there is, this balancing act in terms of children with sore throat, trying to decide which ones would actually benefit from antibiotic treatment. The second bit is that although clinicians, acknowledge that in most cases sore throat is due to viruses, they were really, I guess, wary about with frontline clinicians of missing a diagnosis of group A strep. And third point around so that there's actually limited oversight around antibiotic prescribing at primary care facilities in the public sector. And even the PRINCE study was a lot of hard work in terms of connecting this prospective data from folders as well, particularly in the primary care facilities, because often what we found out and others is that a lot of the antibiotics are prescribed from the consultation room itself, so it's dispensed from the room. And unless you do ask that, there's no record of that. And so that we found out as well in particular. Clinicians also said that writers here, but they did want to refresher courses on sore throat itself. So that's something to think about, particularly offered to frontline clinicians. And there's no system in place currently to actually follow up patients with potential group A streps. Okay. We talked a little bit about point of care testing, that to do this at scale would really be prohibitive in terms of cost, but also you see in terms of the evidence behind that currently. And most, I guess, participants in the room, even though they, this is their field in some ways, were unaware of clinical decision support tools. So the ones that are commonly in the literature would be the Centaur criteria and fever pain most recently from the UK. But weren't aware of even the one that was locally developed, and that is validated for Cape Town in particular. And therefore were not incorporated into any sort of decision making as such. And then I guess the central question is sort of where is the clinical decision tool in the guideline? So these are, just taking three of them at the moment, but what was mentioned is that most of the guidelines follow the standard treatment guidelines. So that's the first thing to say, is that that's where we got a little bit of insight as to what needs to change first, I guess. And there were different interpretations of the symptom criteria. So even if you were to go and compare them, there are slight differences which you can understand why there's a little bit of confusion. The second point, I guess, was around sort of the weighting, the scoring in terms of there is no weighting of the sore throat symptom criteria for sore throat in any of the guidelines. And I asked myself, like, why is that? Why is it that we don't have that? Because it's something that's relatively inexpensive to do, but also makes people think before they automatically just prescribe. And so, and then the second thing was around, sorry, I'm on the wrong slide. In terms of treatment, even though the guidelines all mention sort of a single dose of benzoyl penicillin intramuscular, what happens in reality is that people get an oral antibiotic, amoxicillin mostly, and then penicillin for 10 days. And the main issue around that, I guess there's three main. One was around out of stock issues with the intramuscular penicillin. Also difficulties in procuring some medicines here. And the third reason, I guess, was around sort of the administration. It takes longer to actually do, to put it into, to create, to make up the medicine. And so clinicians revert to sort of what's easy to do. You can understand why that happens as well. But what it has, I guess, what I'll come to is it has implications for what actually happens in the clinic itself. So the next bit, I guess, to ask yourself, what are the implications of what people, these key stakeholders are saying to us? And are we doing more harm than good? There's something called antimicrobial resistance. It's always there, difficult to prove that it's it's there in primary care. We see it often, obviously, in secondary care hospitals, but it really starts in the community. And should we actually sort of, we recognize rheumatic fever is difficult to diagnose, and but we also know that the incidence of rheumatic heart disease is decreasing in our country. We are doing good, but where's the balance at the moment? And that's, I guess, the central question. We don't know. And there's sort of two scenarios in this. One where we have sort of a confirmed strep throat, and we know what to do. It's antibiotics for a child, and that's what usually happens. But we know in this child that there's most of the infections are viral and don't need an antibiotic ever. And so we advise, what you need to do is, and so we know that there are, what we found out from a previous study a few years back, is that there are lots of social determinants of prescribing, why clinicians actually prescribe antibiotics. Okay, they also recognize their patient. They know their patient has traveled X amount of kilometers, costs amount of money, and so many times to get a taxi to get to the clinic. And these are important factors that we can't necessarily change, but we have to bear them in mind as well. So I guess I've summarized that, I guess, the implications to sort of the common themes in terms of what are the implications for clinical practice, policy, and future research. And I guess we recognize that identifying children at risk is challenging. You're not going to pick up all of them miraculously by being better clinicians. We know that probably strep A, the point of care test, is currently brilliant. The costs are just not at scale, essentially. And the central question is whether a clinical scoring tool like the Cape Town clinical decision rule can be incorporated into a guideline. We know it works because you need to validate it in the population that you're interested, so that's a plus point. And also we kind of need to incorporate that weighting or the scoring within a guideline. We'll see what happens, I guess, my big thing. The second thing around sort of policy, I mentioned to you that the standard treatment guidelines is viewed as sort of the main guideline where the other guidelines tend to follow. Okay, and so for policies and guideline developers, can we actually harmonize? It actually happens across the guidelines, which I'm told is not that easy to do. It's not in terms of policy, it's a bit more difficult to do than certain hurdles to overcome. And I guess the last point is around sort of, can we actually include sort of some sort of weighting according to the symptom criteria to remind clinicians actually what is the likelihood or the probability of the sore throat being due to a group A strep infection. And last, in terms of future research, I guess, is to try and implement a locally validated support tool in order to optimize antibiotic use. Whether we include a point of care test, I don't know. It's been done before, but I guess the technology is improving all the time, and something to think about as well. The evidence from Europe, I guess, suggests that many children with rheumatic heart disease never present to care. So it is asymptomatic, or the child is so minimally unwell that they never present to clinical. So that's also something to think about when designing future research. And ideally, you'd want to actually create sort of a longitudinal study where you identify which children actually go on to actually develop rheumatic heart disease. Because not all children with a group A strep go on to actually have rheumatic heart disease. And a plea from the heart research unit is that, which I was unaware, is that there's no national patient registry for children that have rheumatic heart disease, which is something that really is critical almost if you think that this is important. So really something that is able to do. And I guess, yeah, last thing, I guess the take-home message is just really to identify some of the areas that came from this stakeholder workshop and the opportunity in terms of trying to improve and optimize the assessment and diagnosis of sore throat and trying to think about how we can actually harmonize treatment of the sore throat. And obviously some of the implications of the findings, which is a work in progress. So I predicted that half an hour would be good. So I'd welcome any questions, discussions. Happy to do that. And also just to say thank you to the team that actually helped with the workshop, because it wasn't me a studio for working with people from I think in that photograph. So thank you very much,
Thank you.
And happy to answer questions.
Yeah, I mean, there's about 20 people, or well, myself included, online. But the two of us online. But it's lovely to see also so many people in the room. Yeah, I mean, any thoughts or reflections, or and the colleagues online, feel free to add your, yeah, if you want to add your comments in the chat, or put up a hand if you want to speak out. Yeah.
Thanks for the talk. It's so difficult in a primary care setting to expect to have the expectation of clinicians to make the right decision every single time in such a short time with the workload which is unending. And so I suppose you kind of addressed my first question, and that is one would have to look at the cognitive processes of the prescribers and then making the decision to give or not to give an antibiotic. So that's quite an important thing to have looked at. And then the second thing is this, how much are we able to engage our patients in the decision in whether or not we're going to use an antibiotic? Particularly if we uncertain, is this a virus, is it not? And, can I issue you with a prescription in case symptoms get worse or don't resolve by X day?
Yeah.
And then that prescription can be sold without another visit to the doctor. And I mean, so there's overlap with the natural duration of viral versus conveyed infection, the natural course of the infection. So that's not such an easy thing, but so the broader question is, is there a way for us to involve our patients? Because at the moment, we're worried about, we can't handle follow-ups with the workload. But part of that anxiety is mitigated when we look at patients as partners, particularly caregivers of children.
No, absolutely. That's a critical question, I think, and realizing that getting access to any facility, the follow-up, for example, is not very difficult in terms of all the social determinants that people have to do, and also the workload as well. It is just not possible. Do I have an answer for you? Probably no. Yeah. But it's something that we do, because there are important questions to ask. Is like, doing, prescribing 97% of antibiotic to adults and children. For me, that sits uncomfortably. When we think about infections and AMR, and I think we're doing a disservice to patients. There are hurdles, obviously, that we need to overcome, and getting patients and try. I guess the difficulty is that, as you said, the consultations are so short in terms of also kind of the health literacy as well. It's a limited amount of time, and so I guess there's a public health thing in terms of doing, and it is I guess I can say sort of from Europe in particular, is that we don't have those discussions anymore with parents of young children. They are well informed. They have read up, for example, online, for example, around gut microbiome. They don't want their kid to have an ulcer. They're worried about their kid, and you do need to examine them. You do need to do that sort of conversation. You can't take shortcuts, and that actually makes the consultation easier in some ways. You're not having this battle. And that's something that happens over time. It's not something that you can actually have a quick fix. But those are the things that, yes, including patients, including parents, is important, and trying to find out. So I think like a decade ago, I guess, as part of my PhD, I was actually particularly talking to parents and what they understood about the concept of AMR, because it's such a nebulous term that people don't understand. They read about it. It all happens in hospital, it's dreadful, and there's nothing you can do about it. But actually, when my child is sick, I just want antibiotics. And the understanding that why they want that is because some your mom or your family member said, go see a doctor. You need to go see a doctor, because that's what was done 25 years ago. And so one of it is to understand the message around sort of AMR. And there's people that are doing really good work around sort of not simplifying it, but actually making the message more personal. Because it's not about understanding the concept of AMR. You don't need to understand it, but it actually has what are the implications for me and my family, and getting that message right. And I don't think we're there yet, but I think we do need to take that into account. But I don't know if that answers the question I've been talking about.
Yeah, I mean, has there been local work around engaging patients in decision making?
I think that's something to explore. I think that we've done a little bit of work, but it really needs something that's really context specific. That using something that happened in a high income country doesn't necessarily translate to South Africa. So that's definitely one to explore.
Thank you. I did some work on primary prevention and cost effectiveness about 15 years ago, so it's interesting to on rheumatic fever and with Mark Engel and Bongani Yossi. So it's very interesting just to hear the update and to hear some of the progress, but also some of the challenges still. You mentioned around iron penicillin and the register. And I just wondered, I know at the time then there was a Pan-African initiative, to really reduce rheumatic heart disease, and it seems to be successful here. I just wondered what the picture was like in the other African countries involved in that program.
Yeah, I can't answer your question because I'm not involved in that initiative, but I do know that, yes, I think Liesl Wilke now has taken the next step in terms of creating the bigger picture. Because the setup in South Africa compared to, let's say, a low income country, very different setup in other African countries. So it is a good initiative, I guess, and particularly when we talk about other African countries where the access to healthcare is, I think, on par against South Africa. Particularly, you say here, particularly in the Western Cape, access to prescribing is relatively good. Usually, usually I would say not stock up issues, for example. But you do see that even though there is a local guideline based on solid evidence using intramuscular penicillin, people tend to deviate from it for all sorts of reasons. And one of the things that came out, which I didn't really mention in the talk, was people are reverting to the 10-day amoxicillin course, but what happens is that how sure are we that they're actually going to complete 10 days?
Yeah.
And that's something that is done, and then people take a shortcut because for obvious reasons, as we mentioned. But we know that the iron pen is far more effective than the other. So I don't know if that answers your question, but I'm not familiar with the Pan-African.
Thank you.
I had a question for you because I think this national register, how difficult is it to create? Because I think, obviously, I think this has been going on for years.
I remember Mark and Bongani advocating for it 15 years ago. So I'm no longer in touch with what's happened on that. But I also do wonder how difficult can it be to.
It's just trying to connect kind of the.
Seems like a low-hanging fruit to me.
Well, yes, and just to get, because one of the things that Lila Rachel mentioned from the heart disease research unit is that one of the things is trying to actually get data, but most of the data, particularly even looking at an update, what happens is most of the data come, for example, from the provinces that are less well off, particularly the Eastern Cape.
Mhm.
And so we don't really have a picture of what happens on a national basis. You go to a little pockets where we know there's a hot spot,
Yeah.
and we base it on that, but we don't know necessarily how broad.
Mm.
So it's, one of the things, I think for the big picture is how to do it.
Mm. I mean, sorry, is the incidence of RHD really dropping, or is it just that our surveillance is
Exactly.
not as good as it was?
Exactly, but we gotta have, or are we, because the flip side, I think having a chat with Liesl, she said, like, is there a reason why we're doing so well? And I said, well, look at your antibiotic prescribing, it's through the roof.
Mm.
So, and then, we're saying, well, that's why we're doing so well,
Yeah.
because everyone gets it. So
Mm.
it's kind of a flip side, but, what do you do? So, but we know, obviously, we're working with the best available data that there is. How accurate, I don't know.
Mm.
Sorry, there was a question now.
Thank you so much for the interesting thought and research. I think my question was more related to the tool, developing of the diagnostic tool. And I mean, if I think about a longitudinal study looking at the progression from GAS to rheumatic heart disease, it could be years or even more. So, I mean, how do you think we could tackle that? How could we design a longitudinal study? And a registry is also a useful tool that I can put, but those patient cohort is already developed, so it's difficult to identify exposures and risks. So how do you think we could tackle this? I mean, it is something we're looking at, but particularly follow up small children, years, resource limited setting, multiple visits to clinics and swabbing, and colonization does not necessarily mean you're going to have the same clinic. Is there anything you think we should specifically be looking at or including in our research?
I guess it's probably a combination of things. I think it's not necessarily that you're going to test yourself out of this. This is my thing. And I think I'm an advocate for point of care tests. I think if there is a place for it, it can happen. But you're not going to necessarily test yourself out of this. The other way is, so at the moment, what's happening is that how we use the point of care test, for example, is to predict, I guess, which kids are we actually going to do the test on. Like looking at sort of the positive predictive value is low, incredibly low.
Mm.
But so the thinking, if you can, I mean, this is not cost effective at all, I'll say this, but if you were to say, well, look, the flip side is, if you don't have a positive test,
Don't administer.
don't administer.
Yeah.
Okay, and yes, from a cost effective point of life, because it's through the roof.
Yeah.
But at least, you can say that there's a negative predictive value of 90%, that's pretty good.
Yeah, so we rule out is.
But it is something you need to change how you use for setting. But the second point, I guess, if that isn't, you can't do that. If you use a test like that, for example, in a hotspot like the Eastern Cape, where you see a lot of rheumatic heart disease, and in other settings where it's less low risk, use something like a support tool that actually show can give you better insight in terms of what is the probability of this child actually having a group A stroke. And there's a combination of things you do. But I think there is a discussion. I think this is a work in progress. It's not something that I have pursued. The second thing is I think the test is okay. I think in the sense that in a high income country where the prevalence is so low, the incidence probably is so low, using a test like that makes sense. Anything else, using sort of CRP, all of those deflammatory really doesn't. There's no place for that. And the European guidelines don't recommend that absolutely. But it is trying to actually source out which kids you're actually going to test. And that's a clinical decision as well. But again, as I mentioned before, a lot of the kids that perceive, particularly from Eastern Europe, traditionally where the health service isn't that great. Those are the kids actually, but don't even come to GP, they don't even come to the family doctor. So it's almost a subclinical diagnosis, and that's the difficulty we have. So it doesn't.
That's an intriguing question. I'm going to speak frankly. I don't buy the registries for me. The reason I say that is because you can only start the registry with kids that have had echoes and a diagnosis. So you're not,
They're not in this.
they're not in this, you know, and going back in from that point of diagnosis, reversing, doing retrospective studies, retrospective code. These are just mild, non-specific symptoms. I don't think someone's going to remember the sore throat they had 4 years ago or 5 years ago. So it will be good from a quantifying and monitoring perspective, just to say what the burden of disease is nationally. But I don't think it's going to impact directly what we do in primary care. So that's the first point. Second point is probably if you really want to build up a strong risk profiling strategy, you've got to start with a prospective cohort approach, which means you've got to ask, what's my cohort? And how do I collect data in live time from every single member of this cohort, which is what electronic health records can give us. Because it means if we identify 10 single clinics and we give them a full electronic health record, we can follow those kids after 15, 20 years. And we've got data that we can use. Then a whole range of things, kind of what Heather's done out in Paul area with that massive drug constraint project. Because then you're able to build data out of your local population. And then the third question I have, and I don't know the answer to this, but is an antibiotic the only way to prevent this disease? Are we looking at public health type contextual issues that we're missing? So if we talk about building a kind of an at-risk profile, we're looking at biomedical symptoms only. We're not looking at psychosocial contextual issues that also impact. And we don't know, there's no waiting. I don't know if the literature speaks to kids from this background are more at risk, even though they might have identical symptoms to kids from a different background. Nutritional status, access to kind of protein-rich diets, all of these things that are now important for kind of holistic development. Because when we start understanding how the microbiome works, as we are starting to understand now, we recognize it's not just a single bacteria that causes the problem. It's a complex interplay in this microbiome that actually elevates one thing to become dominant at one point. And there's a whole lot of other stuff happening in the background that's impacting on this.
No, okay. No, I'll try my best to answer. We're on the same page. Because I also think going retrospective is just, it's difficult to do. Probably doesn't answer what you really want to answer. So doing it a prospective way, yes, absolutely. I think if I had all Bill Gates' money, I'd put it in electronic medical records because that's where it needs to happen. Without that, it's really, really difficult to do any type of research. So in the Western case, a little bit less. If you do have a database like that, it's just trying to actually optimize that as well. So using it prospectively, yes. I think one of the ways I had in mind, for example, is to actually bring a point of care test in and then follow the kids that have those tests and see what happens. Because to answer your second question, some of the kids, as you know, they present subclinically, they don't have any symptoms. So I probably won't get tested either. And some of them don't even get rheumatic heart disease. So we really don't know at this stage what happens. Absolutely about sort of the social determinants of health, you know, and I showed you in the kind of the very first slides, you know, the kids that get it have a genetic predisposition, very relevant to the Cape Metro region. It's about sort of improving poverty. It's about the nutrition, bigger picture here, and that's where the public health happens. And I think that's what happened in South Africa over the last 30, 40 years is that I would say sort of relative, I mean, it's all relative, but the standards of living have improved for men, not all, but men. And I think that's what's happened as well. There's a little bit of play, obviously, with the antibiotic prescribing. So there's, what impact does that actually have? But it's about sort of balancing it. And are we at the stage yet to make those adjustments as a country? I think that was it. I think.
Maybe just one follow-up.
Yes.
I think that, it took your points I was getting to, but I know cost is a big limiting factor of the point of care, but if we perhaps incorporated it into the diagnostic tool as an optional, and that a negative test should, be scored very highly as a rule out. I mean, if we look at the collateral damage, that I've done a lot of research on strep pneumo and varicella, is yes, you're giving amoxicillin, but you're wiping out the nasopharyngeal migraine. It's not just species, it's strain replacement, so you're actually replacing with more drug-resistant strains, obviously. You may be reducing rheumatic heart disease and HbA-associated strain, but everything else is exploding.
Yeah, particularly in children.
Yes,
You know, we know.
and that under 2-year-old group. Again, with Heather's our study, you see those longitudinal trends up to 10 years. And once you've got those established dominant resistant strains, you can't even with vaccination.
I think, yeah, and to know, I mean, yes, I agree with you, and I think particularly that's where you focus your public health message.
Yeah.
Because if you convince, mom and dad that, wipes out on the floor, and like how you describe that is another thing, but it has really a long-term effect. And every time you have it, that effect is compounded the more often you have. And those kids actually present more often to you. And we have data like that to show that those kids actually present more often to the family doctor. And if that's the message you can actually tell someone who start to take, perhaps that actually will change people's idea. Because it's not necessarily all down to the primary care clinician to actually convince somebody. You really have to take on to it.
Even the delayed prescription of if the child doesn't improve in 2 days, most parents just go with it because we have a kind child overnight.
So we have one online comment from Tiki who asked, made a statement, genetic profiling may be useful in screening for susceptibility, but this resource is not accessible in under-resourced communities. Secondly, one would need to examine zoonotic diseases and how they influence susceptibility.
As I said, I'm not warranted the question, but I do know, yes, there's a genetic position. And Cape Town in particular, work done by the team is that we do know that there are certain genes that actually certain kids have that make it more susceptible. But we don't do that. We don't, outside research, we don't have those research to do that.
I had a question for myself also. I mean, given the complexity of the issue, like I say, both from a preventative treatment and a follow-up perspective, I'm just thinking like typically, and it's good if we had an overview of the guidelines that meant to guide us and not confuse us, especially in a complex environment of primary care where that what category of providers are typically looking after the kids that present the sore throat, and are they necessarily in a position to make the call on the judgment call on like you say antibiotics and then also like you say there's sometimes stock issues with them and so it's a painful injection and then we know that giving often one gets just a 5-day, not a 10-day course. So how can we maybe support and strengthen that crucial interface of those really first line responders that are typically maybe more junior nursing staff, but also some very experienced colleagues, but maybe there's obviously a lot of other system and human factors that are in healthcare, maybe burnout and so on, we think it's just another sore throat, and how not having maybe also always a time to check in with the person's preference and help seeking behavior and preventative education. I know I'm maybe, but I'm particularly keen to think how maybe from that your last set of slides was nice about practice, policy, and research. How we can particularly support the colleagues that are at that interface of that first the contact, where one could potentially make one of the many modes of impact.
I mean, it is a complicated question, Carl. So, I mean, even in a high-income country, people do their own thing, and they have, guidelines and stuff like that. All they're there, they're easily accessible. You really should know them, and still you have, very inappropriate prescribing, particularly for certain. And yes, there is a public health issue, but aside from that, I guess it's also trying to, as we've done, is to try having sort of regular audits and feedback to kind of know what works with certain interventions. And yeah, I guess a good corporate database, a proper review rather, looking at sort of what works for clinicians, what interventions are likely to work at, and this is essentially audited feedback, point of care tests, and communication. Those are the green things that actually, and it's enhanced communication. That's trying to address those ideas, concerns, expectations of patients. Do they actually want antibiotic? Because if you know that from the start, that's you know where to actually target your discussion around that. And then the reason for that, I guess, is we know long term, and obviously this is in a high income country, but we know long term that's the most effective, not the point of care test, by the way. So in a European, pan-European study called the GRACE study, they looked at sort of across 8 different countries, thousands of adults and kids, but they looked at point of care testing and what they call enhanced communication. And looking back, and they stopped the trial and went back again a year later and saw what happened. And people had abandoned the point of care test, thinking, oh, this just takes too much time, and just went around the enhanced communication field, and that worked. And obviously, from a cost-effective point of view, that's brilliant. I mean, that's what you want. So those are sort of the 3 things we think this is where you should be targeting. The reason, obviously, this is all high-income country, but can you actually make it in context relevant for here? And that's where sort of future research needs to be done.
It's not my area of
That's okay.
The community is very good. So I was reflecting on some of the things that Prof said around the system pressures linked to infants, clinician or prescriber behavior. And I was wondering, so a lot of this work was all done in the public sector. And I just, from my own experiences across my family network and looking at different private sector doctors, who are not necessarily, they're busy, but they're not under the same system pressures as we see in the public sector facilities. And yet the behavior, the prescribing behavior is not different. And so I think we should, there's something there that's not just related to the system pressures. There's something about the choice of kind of frontline antibiotics that is, it's across both sectors, and the one influences the other just as much, obviously. So I think we need to look more than just blaming the system.
Yeah, no, absolutely. I think
And not blaming, sorry.
No,
But how do we change behavior?
Yeah, and that's one is around sort of the public health messages. As a parent of 2 young kids, when your kid is unwell, you want them to get better. Even as a clinician who's interested in infections, I don't have the antibiotic. Or just in case, I don't want to come back again. And that's me knowing full well what's going to happen. And I imagine that's what's happening. That conversation is not happening both in the public sector and private sector. And the private sector is different because it has financial implications. If you don't give the parent the antibiotic, they won't come see you again. You're not that doctor for them. But you probably that message that in terms of the antibiotic harm is probably not happening in the consultation. How we fix it is not difficult. There are good people much better than me that actually are doing that on a national basis. They're trying to actually infiltrate that public, the private sector, because that's the real thing. They have all the data, but sometimes very difficult to. So I said there's not a silver bullet. Okay, so I think focusing on one thing, no, but really it's a probably combination, making it sort of context relevant, so what works in that setting.
Last comment, sorry.
Yep.
So there's an interesting parallel one can find in breastfeeding. A few years ago, 12 years ago, a policy came out nationally that we wouldn't be dispensing formula milk to help kids any longer. Only those at risk would get nutritional support. And the expectation is that all new mothers would either procure their own milk or dispense their own milk naturally. And we were, the pediatric staff and primary care were extremely worried. Because they thought we're supporting so many kids in our poor communities that we're going to see an influx of man's moderate acute malnutrition. And we didn't. You know, there was so it was kind of a policy that was imposed on systems, but at the same time there was the kind of the what was it called, the breastfeeding, the breast MBFI, mother baby friendly initiative. Yeah, so you had the MBFI happening at the same time. So facilities were crediting themselves with MBFI, which meant that all of these frontline staff were trained in breastfeeding counseling and how to facilitate that process. And we didn't. We monitored this. We thought we didn't see problems. So I think what you're saying is probably right. If you're wanting to get real behavior change, it's a combination of policy, which dictates what's available, and norms, which dictate behavior. But that was really very traumatic. People said, how are we going to do?
Yeah, I think it's, as you say, it's, you know, this takes time. It's not something you can fix overnight, but I think trying to get people on board, getting those sort of AMS champions at the local sort of frontline level, then policy, and then also your big sort of public health, you know, parents, patients involved group as well. You're trying to change the mindset of what's happening.
So maybe I think to have like our facility is MRI accredited. We do patient education, we do rational prescribing, we do peer review, and we align ourselves with national guidelines all the time. And so that becomes like a thing. But there needs to be someone at the top who's rewarding you, keeping you strong.
That's what the feedback, yeah.
I mean, yeah, I mean,
It starts, antimicrobial stewardship, and maybe also like to say, with the National Department of Health.
In conversation, we can
Office of Health Standard Compliance.
Yeah. It's simple too.
Yes.
All of these guidelines, the EMI, you can just have something to sort of run those things, and there's 76% of probability of not having to. You know,
so those tools like the previous ones, like Kiva Pay, for example, is online. So you literally plug in what symptoms the child has, and it gives you a probability. It is existent, and you can access. You don't need it now, but I do think you do need to use something that's locally validated rather than possibly. And so that's something that is an avenue to.
I think the point of care test, but a point of care decision making tool, it could also. We so out of time, and there's some lovely comments online. Thank you and from to everyone. But yeah, maybe it's good to then conclude. I mean, we obviously you've left your details there, and I'm sure this is the next step to further work. We very good. We never get ourselves out of work. We always create more work with the current work. But it's exciting, and it's so relevant, and it's usually exciting also to see the network that you are bringing together around this issue. And to everyone who has been here online and in person, I mean, it's just lovely to see all the disciplines and the speakers represented. And yeah, we look forward to continue sharing this journey with you, Oliver. Thank you very much. Online, they have joined us.